So welcome to session 10 IGRT clinic share overview. Let me just photos and videos of current setup. So what we're going to do is we're going to kick it off by going through different devices that you can use for setup and why it's important to have a good and reproducible setup for our patient, minimizing motion and intrafractional differences. And then we'll go through different examples of site setups, both from participants, past participants, and from Justin and my clinic. And then we'll discuss kind of what's good, what's non-optimal, how we can set up our patients in the best way possible. So please feel free to ask questions and to give us ideas and things to talk about together. So there's a number of different types of immobilization devices that can be used in the clinic. And they go anywhere from Velcro straps, rings, rubber bands, foam cushions and wedges, to things that are produced specifically for radiation therapy, such as a headrest, cushion, head and neck frames and masks. Index bars, it's important to index our patients so we know where on the table they are and where each of these devices are to be positioned with respect to each other. We'll look at some breastboard options, a prone breastboard, prone belly board, and then different types of body fixation that can be molded to the specific patient, like an alpha cradle or a body fix blue bag. For positioning methods, one thing that's very important once you decide on your positioning method for a specific patient is to do a good job recording that patient setup during the CT simulation. So whether that's taking photos or writing notes, it's good to have kind of a systematic or formatted template where the therapists or the techs that are setting up the patient at CT simulation can record everything that they've done so that it's easily communicated to the treating therapist to get the patient back into that same position. So some of the things that it's important to record would be how the patient was positioned, which devices were used, the index bar location. So the index bar on some CT couches and treatment couches, there are notches that an index bar can lock into so that you know where on the table exactly the patient was positioned or that a device was used. So it's important to note those index locations so that they can be used for treatment. You would want to note any previous marks if the patient has had prior treatment. It can be confusing, especially if the treatment courses are in close proximity to each other. You would want to note, okay, this patient already has tattoos in this location. The new tattoos are in a different location. Sometimes the techs will use 2 tattoos as opposed to 1 tattoo from a prior course. So just to clearly indicate what are the marks for the current treatment. And then it's also good to document the laser positions compared with the tattoos. So if you can take pictures showing where the laser is laying with respect to the tattoos that you're making on the patient. And then also where the lasers fall with respect to the devices. So some positioning devices have kind of a ruler bar or some indicators on the side. And so you can also note where the laser at the isocenter position would fall onto those devices. And that gives the treating therapist a lot of information about exactly how the patient was positioned so that they can reposition them. And then once the patient is on treatment, we have different types of imaging verification that we can take. We can take MV images of the patient, 2D KV images, and also cone beam images. So we can go through site by site how we immobilize the patient and how we can use imaging to check that we're setting up the patient in the correct location for the treatment that we want to deliver. So why do we care about accurate patient localization? When we can line up the patient well, this allows us to use tighter margins for our PTV around the target. So we can reduce the size of the field that we're treating if we know exactly where we want to treat. So accurate targeting can lead to potential better tumor control if you're confident you are not missing parts of the target and that you're really positioning the patient well at isocenter. This can lead to better tumor control. And then also when you're reducing your margin size, you can reduce toxicity and have potentially fewer complications for your patient. And then one method I wanted to mention is the use of fiducial markers can help you to reduce margins and really make sure you're localizing your target. On the left is an example of a prostate patient with markers in their prostate. Typically, when markers are used for prostate positioning, we use 3 markers. And in your planning phase, you would want to contour those markers with a small margin. And then those contours of the original position of the markers can be used in your KV or your cone beam images. You can use those contours to identify where you want to shift the patient. So you want their markers on the treatment day to fall within the contours from your original planning CT to know that your prostate is in the same position as it was for treatment planning. If you don't have markers and you have the ability to cone beam, here's an example of cone beam localization. So you can take a cone beam of the patient, and again, using your contours from your original planning CT, you can make sure you're aligned to exactly where the prostate was at the time of planning. And so in this example, it indicates a 3 millimeter PTV margin for a prostate SBRT was able to be used with daily cone beam and using a VAC-LOCK bag on the patient's pelvis, which we'll show later, as opposed to a 10 millimeter margin, which would typically be used if you're doing once a week imaging and you're just using your skin tattoos. The prostate can move around a significant amount based on bladder and rectum filling. So you have less confidence if you're just using skin marks or if you can't see the prostate or a surrogate for the prostate like markers. So by using imaging or fiducials in this case, you can shrink from a 1 cm margin where you see a significant portion of the rectum is within the PTB field and would be receiving full dose versus a smaller margin where you're just catching a little bit of the anterior wall of the rectum in that case. Okay, with that, I'll kick it off to Justin to go through some positioning for brain and head and neck.
Thank you, Maura. Bonjour. Good day, Africa. So Maura has given really a very nice overview of what we're going to cover today. At a high level, we've talked about different immobilization devices and the rationale for the setup and how imaging may be used to tighten down margins. And so now we're going to start focusing on specific anatomical sites. We're going to start at the head and work our way down to the pelvis. And at a very high level, what we want to do is to reproduce the patient in the same position as at simulation day after day for treatment. Moreover, what we want to do is to minimize the motion of the patient, both in terms of motion between fractions and motion during a fraction. And so how do we do that? We do that with immobilization devices, and we do that by immobilizing a patient in a position which is comfortable. And further, what we want to try to do is to position the patient such that healthy tissues are moved away from the radiation field when possible to minimize the dose to those tissues. And so here we start by looking at the brain and the head and neck. And in both instances, the patient is positioned head first supine. So head first is just simply so that the couch can travel within limits to be positioned under the beam. Supine positioning is preferred over prone positioning because the patient is typically more stable lying on their back as opposed to on their belly. And in both of these instances, the patient is immobilized with a thermoplastic mask, and that's currently the standard for immobilization both for brain and for head and neck treatments. Could we go to the next slide, please? Okay, so for the brain, so where do we start? It really starts with head support. And we can achieve head support either with a generic commercial solution that could be used for multiple patients. So for example, these head supports shown on the left side or have different curvatures that can better match the shape of the back of the head and the neck for an individual patient. And you'll notice that some of those head supports have flanges for the neck, whereas others don't. So in my clinical practice, We use these generic head supports probably for 95% of the patients we treat. And out of that patient population, primarily we're using a number 4. That tends to work quite well. Occasionally, we will create a custom head support. And so that's an example of that is shown at right, where this could be an expandable foam. This allowed to expand to conform to the curvature of the patient's head and neck, with a therapist gently applying pressure around the edges such that it fits within the confines of the mask. And we use the custom head support most often for a patient who is unable to lie comfortably on one of the generic cushions. So, for example, if they've had surgery, if they're especially sensitive, then it may be that we can make them more comfortable and therefore less likely to move with a custom support. Whether a custom headrest or a generic foam cushion, we're typically tilting the patient's head such that the chin is in the neutral position before placing the mask. So now let's advance to the next slide, please, and we'll talk a bit more about how do we immobilize the patient once the head tilt is in the right position and supported. So in the past, we would use tape. We would use tape quite a bit for whole brain radiation therapy, even though now a mask, a thermoplastic mask, has become the standard. I recognize that not everyone has the luxury of a thermoplastic mask, that they may not be available, or they may be, if they're available, they may be reused, and there may be clinics that still depend on tape. What I would like to show is if you are using tape, you might consider 2 straps of tape, one which goes across the forehead, is shown at top, and then another which comes underneath the chin in order to secure the chin tilt and better immobilize the patient. At right, we can see plots showing that the 2-strip technique is a bit more secure in terms of immobilizing the patient. Next slide, please. More often, though, what we recommend is a thermoplastic mask, especially if that is available. And so these thermoplastic masks will come as flat perforated sheets that can then be placed in a water bath or a dry oven in order to warm the mask such that the plastic becomes pliable. And once that plastic sheet is pliable and can be deformed, it is then draped across the patient's face and then secured in 3 locations on either side laterally and at the top of the head. During this process, it is very important to have at least 2 sets of hands, even 3 sets of hands, because the mask does dry or cure somewhat rapidly. And while it's curing, what we want to do is create good contact between the mask and the patient's face. And in particular, we want good contact on the forehead, at the bridge of the brow, at the nose, and then down at the chin. And what you can see is that first the contact is made at the forehead and around the bridge of the nose in the upper left image. And then once that firm contact is made, then the therapist is working down towards the chin. In our practice, we will commonly roll back or flip out the lower part of the mask before making contact with the chin, just so that that area is a bit smoother where it makes contact with the skin of the neck, such that it's less likely to poke into the patient. Something similar can be done with other aspects of the mask that make contact with the skin. You'll notice that in this case, this mask is a closed face mask. That is, the patient's eyes are covered. Now, it is possible to cut the mask, and in this case, you'll see that the mask has been cut at the location of the nose, but I would encourage you to be somewhat cautious not to cut too much, because if we cut too much, then we lose some of the rigidity of the mask, and it may not be quite as secure for immobilization. That noted, there are patients who are claustrophobic, and so we need to have consideration for those cases. Next slide, please.
Justin, there's a question in the chat. I was wondering, I think the person was wondering when is it ever acceptable to use an open mask?
That's such a great question. Let's go to the next slide, please, and I will show you an example. So here on the left is an example of an open face mask. And so what you'll see is that the patient's eyes and nose are fully exposed. And this type of mask we actually use routinely in clinical practice. And in fact, we use it routinely for stereotactic radiosurgery, where the requirements for immobilization are a bit stricter than for whole brain or even for partial brain radiation. And these masks are used in clinical practice for patients who are claustrophobic. So here the patient would be able to see and not be restrained. And so that would be one indication for an open face mask. Another indication for an open face mask is when surface guidance is used in conjunction with the therapy in order to evaluate for any motion during treatment. So surface guidance would be, those optical cameras would be able to see the true surface of the patient as opposed to just the shell of the mask. So that would be another example of when we would want to expose the patient with an open face mask. I hope that answers the question. If it doesn't, I can pause. Okay, so another consideration with brain treatments, whether it be radiosurgery or partial brain, is the patient's hair. Now, patients who have more hair, unlike me, are more challenging to set up and to do so reproducibly. So care really needs to be taken to position that hair consistently at simulation such that it's out of the way and then day-to-day on treatment. And so a good example of that is shown on the left, where the patient's hair is brought outside and opening of the mask. Now, we want to educate the patient and encourage the patient not to change their hairstyle during treatment. So at right, if a patient comes in with dreadlocks, what we don't want is a substantial haircut where much of the hair is then gone during treatment, because the mask would no longer fit securely. We would no longer have the ability to immobilize the patient as well as we need to for treatment. Next slide, please. So what about setup uncertainties, and how well do we need to localize the patient for treatment? Well, for whole brain, the fields can be quite large, and small shifts or rotations may not have any real importance in terms of clinical endpoints. However, that's really not the case as we start using more conformal therapies for partial brain, and in particular, very conformal therapies for stereotactic radiosurgery. And so a trend in clinical practice now is to start treating multiple targets within a single plan. So in the past, we would treat one lesion at a time. And so if you think conceptually of a lesion as being a small ball, and our plan is centered on that ball, and if we have a small rotational error or setup misalignment, then that round ball is still a round ball. And so the dose may conform quite well to it. However, if we then change and start treating multiple targets at once, so for example, as shown in this image on left, where we have a single plan where that isocenter is positioned midway among all those different targets, then if we have rotational errors, then what we can see is a lever arm effect, where there is a greater displacement as a function of both the amount of the rotation and the distance between the target and the point of rotation. We did a study a while back at my institution looking at how the amount of rotation and the distance to the point of rotation can affect target coverage. And what we can see is that even at 1 degree rotation, we can really start seeing drops in target coverage. And at 2 degrees, target coverage can really be substantially compromised, in particular for targets that are spread across the brain. And so I do want to point this out to you in terms of the need for secure immobilization, for the need for 6 degree of freedom corrections, that is with a robotic couch, if you're using this type of technique. And then I would also encourage some type of patient monitoring during treatment to make sure that the patient has not moved or rotated. Next slide, please. So what about for head and neck? So we're moving down a bit more away from the brain. And in this case, the setup is very similar in terms of considerations with patient positioning. So again, the patient is head first supine. Again, a thermoplastic mask is used for immobilization, but there are a couple of differences which are worth pointing out. So in this case, instead of having the chin in the neutral position, we now use a wedge underneath the patient support device to tilt the chin up or to extend the chin. And that is done such that the chin is positioned away from the neck nodes, which are often treated because we want to spare the mandible and the healthy tissues around the mandible from excessive radiation dose. Additionally, the shoulders are an organ at risk, which we want to move away from the field, to move away from these neck nodes. And so that is done in two ways. One way is that the patient may hold on to straps such that the arms pull the shoulders down and away from the field. And then further, you will notice that the mask is now longer and it goes down and it covers the shoulders. And so when the mask is being made, in this case, we would actually want 3 sets of hands. So 2 sets of hands working up top on the head and neck area, and then a final third set forming the mask to the shoulders and pushing them down and out of the way so that beams can come in laterally to treat the neck nodes without first passing through the shoulders. Next slide, please. So head and neck patients may have disease which extends close to the skin surface. And when treating with photons, that superficial disease could be in the build-up region where dose is lower than what it is at Dmax and beyond. And so in order to get adequate dose brought more superficially to cover that superficial disease, bolus could be used. And now bolus, which is a tissue equivalent material, it can be modeled in the treatment planning system and then added after the fact. However, I would encourage you not to do that. I would encourage you to add the bolus at CT simulation, to add that bolus under the mask, to build it into the mask. And in doing so, what can happen is you can minimize the air gaps and thereby improve the superficial dose. And moreover, you can make the bolus positioning more reproducible by building it into the mask. Whereas if we create a virtual bolus in the planning system, it then becomes quite cumbersome to fabricate, to implement, and place that bolus. And in some cases, as shown here, there's no possible way that we can design a bolus that goes from the chin all the way under the patient's neck, making contact with this headrest, making contact with the mask, and further matching the concavity of this complex anatomy and to physically be done. So bolus may be needed whenever possible. I encourage you to use bolus at CT simulation. Next slide, please.
Excuse me.
Yes.
Why the bolus goes along to the shoulder?
This is a bad example of what you should not do.
Okay, thank you.
And so, however, in the treatment planning system, the tools are not quite sophisticated enough to design a bolus in a very intelligent way, which would just cover the superficial disease and not expand more broadly. Now, there are ways to trim down the bolus, there are ways to tighten it down, but if the treatment planner is in a hurry and they have many, many cases to do, it may be that they design a bolus that's just simply not physically realistic. And that's what I'm showing here. Any other questions regarding virtual bolus?
Excuse me.
Yes.
I'm just asking about the bolus. If we make it in the plan system like a virtual, what's the difference between that one and when I put it in the CT planning?
Well, if you're able to design a physical bolus which matches the geometry of the virtual bolus, and if the density of that bolus is the same, and then further, if you place that physical bolus exactly in the same position as the virtual bolus, then it's equivalent. Where we get into trouble is if we're not able to reproduce that.
That was I'm asking about this one because sometimes when you work in virtual, you cannot do the same in the treatment area. So it maybe have some air under this one or between the skin and the bolus. Also, I'm asking also about how to put the bolus over the mask. It's possible or not?
Okay, and so this is a very good point, and the issue of air gaps was raised. And this virtual bolus is really perfect or ideal in the sense that it perfectly conforms to the patient. Whereas in reality, with physical bolus, even when it's placed at SIM, there could be air gaps, which are undesirable. However, what we want to do is model those air gaps in the planning system. And further, we want to minimize those air gaps. The best way to minimize the air gap is to place the bolus directly on the skin surface and to then form the mask around it and to very intentionally place hands over that part of the mask as it cures in order to have a very snug fit such that the bolus is in good contact with the skin surface, and further such that the mask has an outline or an edge which encompasses the bolus so that essentially the bolus is built into the mask so that when the patient comes back, that bolus is embedded and then it is positioned very snugly onto the skin surface. Now, if you create a virtual bolus and then attempt to place that physical bolus after the fact, you've lost that luxury of building it into the mask. And if you position it on the skin, well, then we have a hardened mask going over it that may compromise the contact of the mask with the patient otherwise. And further, there may be air gaps, additional air gaps because of that hardened mass not being quite as snug against the bolus. On the other hand, if you were to place the bolus on top of the mask, then you necessarily have a perforated boundary of the thermoplastic mask with small air gaps between the bolus and the patient. So whenever possible, I recommend positioning the bolus directly on the patient's skin at the time of SIM and then building the mask around it.
Actually, sorry for the question, last one. What about if we treat it like this tumor and the tumor like shrinking after a couple of stations, something like this, and we have to make replanning what's happening for this one because the bolus and the mask will be away from this one. There is a gap. It will be a gap between the skin.
Yes. Yeah, that's such an excellent point. Head and neck patients will commonly lose weight over the course of treatment. In some instances, there can be substantial tumor shrinkage too, both of which can lead to air gaps. It is quite common in our clinical practice to monitor the patient for such changes based on a cone beam CT, and then when warranted, based on that information from IGRT, adapt. And so that adaptation could involve adjusting the mask to minimize the air gap. It may be a full out replan with a resimulation to account for those differences.
Thank you so much. Thank you.
You're very welcome. Next slide, please. So some patients are kyphotic, and our recommendation for kyphotic patients is not to try to make them straight or flat on the table, but instead to build up the mobilization devices to meet them. And what I want to show in this example is that the angle of the wedge underneath the headrest is reversed. So typically, the toe of this wedge would point towards the patient's vertex of their skull as opposed towards their chin or their body. But in this instance, we have flipped it around such that we can better match the curvature of the neck on a kyphotic patient. Next slide, please. Scalp patients are another type of head and neck treatment in which the treatment setup can be quite challenging. In particular, it becomes quite challenging when the extent of the disease expands over a large concave area, such that a single on-phos electron field is no longer adequate. And in this case, we're going to consider multiple photon fields or arcs that come in tangentially to hit the scalp, that is the disease, while at the same time avoiding the brain, which is often in between, right? And so in these instances, again, we want to fabricate bolus at the time of simulation. That bolus could be fabricated by cutting strips from a sheet of superflab or silicon and then creating something which looks like a helmet that is positioned over the area to be treated. Alternatively, thermoplastic sheets could be warmed and then formed over the area. The challenge with the thermoplastic sheets is once that plastic hardens, it can become a little bit pointy and can press into the patient, and over the course of treatment, this can become uncomfortable. At our clinic, we have evaluated custom boluses, so silicone which is designed and fabricated from a 3D print on a patient-specific basis. We have also looked at generic swim caps made of silicone and compared that to cutting sheets of flat bolus to fabricate these helmets, and this is publicly available. And so if you want to check out that bolus study and then also look at optimization techniques, a link is included here to that paper. Next slide, please.
Justin, there's a question in the chat. They're wondering the bolus thickness in the scalp.
So the bolus thickness, which we typically use clinically, is half a cm. There are other practices that may use a full cm of bolus. Next slide. Okay. I'm going to hand it back off to Maura.
Thanks, Justin. Thanks for that great discussion. So now we'll start talking about breast. There's a lot of different immobilization devices that can be used for breast. Typically, again, patients are more often positioned supine out of comfort. We'll talk a little bit about the benefits of prone positioning in some patients, but the majority of breast patients are generally treated supine. So here we have a patient positioned in the supine position. We like to treat the patients with their arms overhead. There are studies that having both arms overhead leads to the most reproducible positioning in terms of symmetry and patient roll. It's easier when both arms are up to get kind of that straight, symmetric, reproducible position. Of course, there are times when patients are not able to raise both arms overhead. So for comfort, we would allow them to position their contralateral arm down at their side. But the ideal is that both arms are up overhead. And you can see on this patient is positioned in a breastboard. The breastboard is angled a little bit off the table, and that's an indexed and recorded angle that you would have for that patient. And then also there's an indexed angle for their elbows. So you want the arms to be as comfortable as possible overhead because the patient has to stay in that position, for several minutes throughout the course of their treatment, and maybe even longer at sim. And then usually above their head, there's either a bar, which I might see here behind the patient. Usually there's either 1 or 2 bars that the patients can hold on to, again, in an indexed position, or as you see here, there are supports for the wrist. So we try to get the patient's arms up overhead. We want the patient to be as straight as possible. And then in this case, when a patient is on an angle, it's good also to have what we call a butt stop, but a positioning device for the legs that kind of makes sure that the patient's in the same position, their body is in the same position along the board. Some boards have a ruler along the side, so you will be able to kind of mark where the laser falls at isocenter on the board. I mean, you could even put a ruler or attach a device along the side of the board that would allow you to record that, so you can make sure that longitudinally the patient is in the same position on the board. And here you can see with this positioning device for the legs, You could also use an index bar, and there's different positions for the index bar, which you could record. So then you know where this device is with respect to where the breastboard is.
Maura, there's a question in the chat wondering, I think Lydia wonders that if the patient has to have their head turned to one side or usually it's faced up.
So usually we would want the patient's chin to be hyperextended if we can, just to make sure it's as far out of the field as possible. And then if we're treating the supraclav nodes, which are higher up, generally we turn the patient's face away as a further precaution that they're away from the entry and exit dose of the nodal fields. You can see that this patient is a post-mastectomy patient, and it looks like they're marked where their isocenter would be. That can be difficult sometimes for intact breast patients, because if you're marking the patient on their breast and they have a pendulous breast, it's not really a reproducible mark on the body that you can line up to. So in my experience, sometimes we will mark the patient on both sides so that we can, in an area kind of lower down and off of the breast, so that we have somewhere where we can make sure the patient isn't rolled, and that we have them laying with the same roll flat on the table as we did at simulation. And then, so we would have a triangulation point lower down in a more stable area for marks on the body. And then we would communicate the shifts up to the breast isocenter from there. So just to give yourself kind of a stable starting point. Frequently, if you have marks on the breast can fall differently, and it's not really the best spot to start your setup for the patient. Here's another example of a patient positioned on a breastboard. Again, this breastboard looks like this board has a ruler along the side. The angle is in an index position that would be recorded, and same with the arm supports here to get that patient into the same position every day. One thing I noticed with this example was that it looks like for comfort, the patient has kind of folded up blankets under their back. The board can be uncomfortable because you're laying on this very hard thing, but I would caution against something like folded up blankets under the patient for support, because the thickness and the angle of anything that you put behind the patient is really going to affect the breast and chest wall position. And this would not be something you would be able to reproduce easily every day. So you would really want the patient laying flat on here. If there is a need and the patient really cannot lay on something hard, a better option might just be a uniform pad that you could put under the patient, like a styrofoam thing or some kind of material that you know you're putting the same thickness in every day for the patient to lay on, so it won't affect the angle of the patient's back in this way, which will really change kind of your treatment area.
Maura, I think Mohammed is wondering, like, how do you determine how much inclination that you need in the back, I guess?
Okay, that's a great question. So I think that the angle of inclination used to be a lot more critical in conventional planning when we weren't acquiring CTs of the patient. I think now there have been studies that you can get equivalent plan quality if the patient is lying flat or if the patient is angled. But one benefit of having the patient angled is that you have gravity kind of weighing the breast down and kind of down and away from the chin. And gravity helps the breast to fall into a more reproducible position. I believe it used to be that the angle you wanted to have kind of the chest wall horizontal here. That's less critical when we're doing 3D conformal planning, because we have a CT of the patient and we're setting up the collimator angle to align with the chest wall. And we can use asymmetric jaws, field and field delivery. So the exact angle is less critical. Justin, I don't know if you have more input on this. I think frequently our therapists leave it at a single angle so that they don't have to kind of reposition the board for each patient.
I think you've explained it very well, Maura. The only thing I would add to that is that if the angle becomes steeper, the patient becomes higher on the table, and there is an increased risk of a collision.
Thank you. Yes, great point. Great point.
Excuse me,
Mhm.
do you mean that we don't use this increasing immobilization for 3D conformal therapy?
Yes, we do still use this. We do still use this immobilization, but the exact angle is less critical.
How much exactly?
How much of an angle do we use?
Yes.
I think ours is usually set at 15 degrees.
Okay.
And here is just another example. I think here I was looking at the chin position. So it looks like this was when here's a patient that's being simulated flat. And it looks like when the patient first laid down for the simulation, you can see her chin is not extended and could become an issue in most likely the exit dose of the lateral tangent beam. And then you can see when her position is finalized for the sim and they're preparing for her marks, she has her chin raised. And you can see there's much more clearance here for the tangent fields, as opposed to here when she first laid down, you can see that the breast tissue and the chin tissue would kind of be in the same plane. So here's an example of where hyperextending the chin would be really helpful. And this also shows you an example where the patient might be marked kind of at a stable location. And again, this may not be the practice everywhere, but I think that having this mark on the contralateral side is also a helpful starting point for your therapist when the patients first lie on the table to make sure they're not rolled to one side. And then you may have an additional mark where they shift to for isocenter. But again, the marks on the breast are less stable of a guidance point for you. Here's an example of a prone positioning board. So I think prone positioning can be advantageous for some patients, especially for large-breasted patients, maybe left-sided large-breasted patients. It has been shown to reduce heart and lung dose for some patients, but the setup can be a little bit more tricky, and also your clearance of the gantry to get around the patient can be tricky. But this is another option for positioning, and this is just one vendor example of a prone breastboard. And Justin brought up this idea earlier, how we have to be cautious of clearance when we have the elbows kind of high or the patient angled high on the couch. We always have to keep in mind that we have to be able to get the gantry around the patient. So here's a patient being treated to their upper extremity. So, some things that become important are separation from the head, or separation between the target and other normal tissues like the head, putting something in between there. It looks like there's maybe a custom cushion here to kind of reproducibly position where this patient's wrist is, which will help stabilize the angle of the arm. And then this looks like a 3D simulation. Justin, do you want to give us a little info about this?
Yeah, so this is collision check software that we're using clinically. And what you see with the green curves, that is mapping out the rotation of the gantry. So we're seeing like the face of the collimator head as it moves around the patient, which is shown as the yellow surface. And the table is also shown in yellow. And this is an instance where the elbow would actually intersect with the gantry as the patient is positioned now. And so clearance is certainly a concern for this type of treatment.
Thank you. And I think one thing that just came to my mind with these breast simulations that I did not see. I think it's somewhat common in the facilities I've worked at for the physicians to put wires or marks at the kind of end of the palpable breast tissue. Sometimes in the CT simulation, it's hard to determine where the fields should end. So it is somewhat common for the physician to put either wires or BB marks to kind of mark out on the patient at simulation where they would want their breast fields to end. And that can help you in setting up your tangent fields in the treatment planning system. Okay, with that, moving on to thorax, I'll hand it over to Justin.
Thank you, Maura. So for thorax treatments, the patient is typically positioned head first supine. We often use a wing board for immobilization, and so you can clearly see the wing board in the upper right image, and the arms are raised. So same considerations as for breast. A challenge is that many patients have arthritis or pain such that it may not be possible to easily move their shoulders or move their arms upward because of shoulder pain. In that case, there can be an upfront conversation with the physician and nurse about pain management, and then we can do some things on the back end to provide a bit more support, either with a towel or a cushion to make it a bit more comfortable. What you'll notice in this case is that the patient's hands are holding on to lock bars, and these lock bars are indexable, and that is used to more consistently reproduce arm positioning. Now, one very, very important consideration for thorax treatment is respiratory motion management. That is that the targets and the organs at risk are going to move with respiration. Next slide, please. And so in clinical practice, we are using a 4D study to characterize that motion. And what you see on the image at left are contours. And if we looked at the lungs, for example, we would see a white contour that represents end exhale, and then a red contour which represents the inhale position. And so there's actually a substantial difference in the lower boundary of the lung depending on the phase of respiration. Likewise, there is a target nearby, or not so far from the diaphragm, that also moves substantially with respiration. And so by acquiring a 4D CT image, we can then account for that motion envelope, both of the target and of the OARs. And in some instances, all we need to do is add a margin such that the fields are sufficient to encompass that motion envelope of the target. But in other cases, that motion envelope or that excursion is quite large, and there can be unacceptable field sizes, which could potentially increase toxicity and not be desirable for treatment. So then we need to do something more to manage respiration. So let's talk a bit more about that, and it's based on guidance from APM TG 76 report. I've shared that link here. And let's go to the next slide, please. So the first step that is often used to mitigate respiratory motion or to reduce the effects of that motion is compression. And by that, I mean abdominal compression. And abdominal compression can be achieved by wrapping the patient with an inflatable belt, which can then be inflated to put pressure on the diaphragm to restrict the amount of motion. Alternatively, another device, as shown at right, might be used in which there is a bridge over the patient and then a paddle that goes down. And so this paddle can be pressed into the diaphragm and tightened. These settings are recordable and indexable, both for the belt and for the plate. There are instances, however, where abdominal compression, despite however well it may restrict the surface motion, does not provide adequate restriction of the internal anatomy. Next slide, please. And so in those instances, we may consider other forms of respiratory motion management that could be breath hold, in which case we ask the patient to either take in a deep breath and hold it, or we may, and less commonly, ask the patient to breathe all the air out and then hold their breath in the expiration position. In either case, patient selection is key. So we need a patient who is able to consistently hold their breath for about 20 seconds or so, and to be able to do that repeatedly. So up to 10 times during a fraction of radiation therapy. There are patients who are unable to hold their breath, where compression does not work effectively, that still need some form of respiratory motion management. And for those patients, we may then consider phase gating. And so the notion is that that patient would have a fiducial block on their diaphragm, which moves up and down with respiration. And that signal, that indication of inspiration, the peak on this curve, or the expiration valley, can then be linked to the 4DCT in order to only treat during a subset of those phases. And commonly we would treat during the valley, the expiration, because that tends to be more stable than the peaks. Of note, which I should have mentioned earlier, this same type of fiducial block can be used for the breath hold treatments to determine the position or the excursion of this fiducial marker, and then relate that to a CT image, which is used for planning. Next slide, please. Here's an example of a mesothelioma case, in which case the outer lining or boundary of the lung is being treated. Breath hold was ordered by the physician if tolerable in order to freeze the motion such that we can tighten down on the margins and the size of the radiation field. The arm was positioned akimbo to move it away from the field. In this case, it may be that the patient was unable to raise their arms above their head. Unfortunately, this patient could not tolerate breath hold. And in this case, it was also found that the patient could actually put their arms over their head, and that would be better for treatment in terms of sparing and in terms of reproducibility. Next slide, please. Okay, and so now we are in the abdomen, and I'm going to hand off to Maura.
Okay. And I'm just noticing that we're coming up on 11 o'clock, so we may have to go a little bit quickly through these. But I think this slide, we're just pointing out some challenges with simulation for the abdomen and with different methods of compression. For example, how high up do we need to compress the patient in order to minimize motion? For these devices, it can be complicated to decide once they're in place how to tattoo the patient. And then with any compression device, we really have to keep in mind, is the patient comfortable enough to stay in this position for potentially a long time? And we have a reference here with more information about the impact of abdominal compression for patients treated with stereotactic body radiotherapy. Okay, as we move into the pelvis, just some key concepts. There can be a lot of different target volume types in the pelvis, which can affect the way that the patient is positioned. Generally, supine positioning is the most comfortable for the patient and the most reproducible in terms of pitch and rotation of the pelvis, because when you're laying on your belly fills differently, and it's difficult to get the same roll, pitch, and rotation for the patient. So these patients are examples of patients positioned supine. It's important to kind of get a reproducible position for the legs and to maintain the same kind of rotation and positioning with respect to where the pelvic target is treated. So here, this patient, it's hard to see, but under the paper, they have a knee support that keeps their two knees separated by the same amount and at the same angle. And it looks like that it has an indexed position on the treatment table. Here's another example of a patient who does not have support under their knees, but has a device. And again, this patient has a device that will keep their feet at the same angle and with the same separation. And so that helps with the rotation of the hips and the positioning of the pelvis. And then you'll notice these patients all have their pants pulled down below where we're treating. That can be critical because when you have pants with elastic and different thicknesses, it can really distort the soft tissue around the pelvis. So it's important to have the patient pull their pants down and out of the treatment field. These patients, you'll also notice, have their hands high up on their chest. That's important for clearance. It's not always clear at the time of simulation how high up nodal volumes will go on a pelvis patient. So out of caution, it's easiest to keep the patient's hands high on their chest, clasping each other. Sometimes a little ring is used for patient comfort. Here you see examples of two patients set up for a pelvis treatment. They both have rings in their hand and they have different kind of immobilization devices in the area of their legs. This is just showing keeping the same angle of the knees and separation of the legs. Here there's a generic pillow under the knees, but the feet are separated and the angle is controlled because that affects positioning of your femur and your hips. These patients are covered for privacy, but it is important not to use heavy or thick blankets on the patient in the treatment area. Here's a patient, it's unclear if the treatment target here is in the abdomen or in the pelvis, but one thing you'll notice is if you don't have something to index and immobilize the legs, it's easy for the patient to be really angled on the couch with the feet just freely lying. There's no way to kind of control the angle or the separation of the legs. So this would not be ideal immobilization for the pelvis. If the abdomen were being treated and you don't have a cushion or a method to immobilize the patient, one thing you could do is, in addition to the mark on the patient at the ISO center, you could place a mark maybe 10 cm superior and inferior just to get you an idea that the patient is straight, that the lasers are aligning to those marks, and that you're in a similar position for treatment as for simulation. Here is a prostate patient. He has a vac lock for his legs. So again, the vac lock would form around the patient's legs. So it's soft and filled with beads. And then when the air is sucked out, it hardens and forms to the shape around the patient. So this is a good way to get the patient's legs separated, to kind of have an indexing for the patient's feet. And we have the hands up here holding a ring outside of the treatment field. However, this patient internally at the time of SIM had severe constipation, which later resolved. And so then the seminal vesicles were no longer covered by the PTV. So it's an important point to remember in the pelvis, in addition to your external immobilization, you have so much going on internally to keep in mind, such as a very full rectum at the time of SIM can really push your prostate or your GYN target anteriorly. And then if the rectum empties, your target can actually drop out of the field. So this is a point where cone beam imaging and on-treatment imaging can be really helpful to tell you, even though you have great immobilization outside the patient, you need to keep an eye on what's going on internally as well, such as bladder filling, rectal filling. You can see a very full rectum here, and then the rectum is empty in the onboard cone beam imaging. Here's an example. As I mentioned, you can have all different types of targets in the pelvis. So here's a pediatric Ewing sarcoma patient, and the target was in close proximity to his genitals. So the best positioning for him, we wanted to get separation of our OARs from the target. Here you can see his target drawn in the CT. So there was kind of a custom, this was actually a head cushion was used to kind of support and separate his genitals and keep them out of the treatment field as best as possible, and frog leg his knees to get some separation in the back lock. And then I just wanted to note, it's important to take these pictures at simulation. So they put just a piece of tape with some dots where the laser fell on the back lock. The back lock has a little bit of freedom to move on the table. So by marking that, you can make sure to have everything aligned the same way it was at simulation. I wanted to give some resources about prone versus supine positioning. So prone positioning in the pelvis for some patients can reduce the overlap between the target volume and the bowel. So the prone positioning can allow the bowel to fall more out of the field, especially for a target like a rectal target, or when you're treating nodes superiorly in the area of the bowel. Prone position with a belly board can provide superior bowel dose sparing to prone positioning without a belly board. So the key to the belly board is just having a hole for the bowel to have space to fall forward, as opposed to just laying prone on your stomach. If you're laying on your stomach, you're kind of compressing the bowel posteriorly. One caution is that prone positioning can result in greater setup error, necessitating more frequent imaging or daily cone beam CT. And then for patients where you're treating the inguinal nodes, you can have generally more reproducible setup and easier treatment planning if the patient is supine. But these are really good resources that go into detail about the benefits and cautions of these setup positions. So there's an Astro clinical practice guideline for rectal cancer, and then an ECOG Akron guideline for anal cancer. And they have some great images and examples of setting up the patient. Here's a patient where frog leg positioning was found to be ideal, and a wing board was actually used. Just flip the wing board around and use a back lock bag here to kind of support and immobilize the legs in that frog leg positioning. And there are also some good examples of bolus, as Justin had a great discussion earlier about the importance of making an attempt to identify patients who need bolus ahead of time and to apply the bolus if you can at the time of SIM, especially for some of these patients where you're trying to fill cavities with the bolus to treat a superficial target. If you can get that bolus into position, you have a better idea of what the air gaps will look like and what's achievable in this geometry when you go into your treatment planning. The treatment planning system can generate a beautiful bolus, but it can't necessarily be executed for the patient. Here's an example of the belly board. This is what the actual board looks like. Here's an image from a CT. You can see how the bowel is kind of falling into this hole, which would be in the patient's stomach area. And here's a patient laying on the prone board. And this was another example we saw with additional immobilization on the prone belly board. So the patient lies down, there's generally support for their ankle, and this looks like almost like a mask was formed around the patient to make sure the patient is positioned correctly on the board. I'll hand it over. If there's no questions about the pelvis, I'll hand it over to Justin to discuss some additional devices we may not have spoken about.
Okay, thanks, Maura. So let's briefly touch on additional devices, some other considerations for the IGRT workflow, and wrap up the session. In the upper left is an alpha cradle. So this is a full body immobilization device that is created by pouring expandable foam into a bag, which then expands and hardens and forms to the shape of the patient. So this is per patient, it's not reusable. An alternative below that is a vac bag, which is under vacuum. And so when it has some air in it, the styrofoam balls freely move about. A therapist will then form this bag to the patient's contour. The bag is placed under vacuum such that it becomes rigid and conformal. And then further, a sheet is draped over top of the patient, which is also placed under vacuum for extra immobilization. In the upper right, we see a custom headrest that is made from a foam cushion. And then the bottom, we see a wedge, an indexable red wedge under the patient's knees, and then rubber bands around the patient's feet, which are used to secure the feet and thereby stabilize the rotation of the legs that can actually have consequences all the way up into the pelvis. Next slide, please. Okay, so what devices should we use? Is it always best to use advanced devices like BodyFix, blue bags, or vac locks? These bags are great for secure immobilization. These devices are not used for every patient in our clinical practice. We tend to reserve these types of immobilization devices where an extra degree of immobilization is needed, for example, with a stereotactic procedure or another procedure in which the dose is quite conformal and the margins are quite small. For palliative cases, we wouldn't use these devices. We wouldn't put forth the extra time and energy and require the patient to spend that additional time in our department. Next slide, please. Here are examples of two prone devices which have been covered previously for prone breast, as shown at top, and then a belly board which is used for prone pelvic treatments, as shown below. Next slide, please. Okay, it's been mentioned for several disease sites about the importance of indexing, about the importance of tattooing the patient. It is also so important to mark the immobilization device itself, to put on lines for leveling, to put on lines for aligning to lasers. And so that is what is shown here. And this is all for the sake of getting the patient back into the same spot reproducibly day after day for treatment. Next slide, please. It's so important to take good notes at CT simulation that get passed on to the treating therapist. It's also important to take good notes at the time of treatment planning and to send over that communication to the treating therapist. Here is an example of SSDs, which can be measured on the machine with an optical distance indicator or front pointer as confirmation that the patient is in the correct position. It is also important to share any shifts between how the patient was zeroed or marked at the time of CT simulation relative to where the isocenter is of the treatment fields. Next slide, please. Here is an example of a simulation report. This type of form can be used by the physician to indicate how they want to position and immobilize the patient for treatment. And this type of form can also be shared with the treating therapist in conjunction with setup photos, in conjunction with other notes for positioning at the machine. And in this case, the physician is also specifying the scan borders, so the extent of the such that all the relevant anatomy is included for the purposes of treatment planning. Field borders could be indicated as well, along with an initial reference. Next slide, please. So when transitioning from 2D based radiotherapy to 3D based therapy, which is really the focus or the intent of this seminar series, there is the opportunity to tighten down fields, to shrink those margins, and thereby spare healthy tissues to a greater extent while still adequately covering the target. This figure shows uncertainties or residual setup errors based on aligning the stem marks at top, which tends to be the least reliable. Then with the addition of some amount of imaging, first on a weekly basis, and then on a daily basis, and then with greater sophistication in terms of that imaging going from 2D imaging all the way to 3D imaging with cone beam CT and aligning to either fiducials, the soft tissue, or the soft tissue. So there is an opportunity with 3D planning to tighten margins. So this is really the impetus that was discussed at the beginning. Let's go to the next slide, please. And here's an overall view of that workflow. And so 3D planning starts with a TSIM. There may be additional 3D imaging from other complementary modalities such as MRI or PET, in which case that data can be co-registered or fused with the CT planning dataset. When you have the ability, it is preferred to position the patient the same way, both for the planning CT and for the MR and the PET CT, such that the alignment process or the fusion process is easier and more reliable. And then this 3D data is used for dose planning. And further, these images are used for the match at the machine. And that match can either be relative to a 2D digitally reconstructed radiograph, or it could be relative to the 3D data set, respectively using paired two-dimensional images or a cone beam CT for a true 3D match. And the notion is that these images then guide how to fine-tune the patient positioning and get them into a better spot for treatment. Further, this IGRT, or this information, in particular when it's a 3D cone beam CT, can be used to evaluate any changes in the patient's body habitus or changes in tumor volumes that could then prompt a repeat simulation when needed. And so at a bird's eye view, this is the IGRT workflow. Next slide, please. And so I just want to conclude by cautioning that as we talk about tightening margins, it is so important for the physicist to have a very rigorous quality assurance program in place that verifies the accuracy of the CT simulator, of the linear accelerator, and even more rigorous still, if stereotactic treatments are going to be performed on that machine, whether it be in the brain with radiosurgery or in the body with an SBRT technique, and here are APM task group reports that can give that additional guidance in terms of the machine requirements for these different types of treatments, such that if you were to tighten down your field margins, you could have confidence in the machine being able to deliver that treatment safely without potentially missing the target. And so next slide, please. This sums up today's lectures. Thank you so much for those who have attended. I know that we went longer than anticipated, and yet over 150 people have remained on the call. And a special thank you to our interpreter, who is so beautifully speaking in French for the audience and who has stayed on longer with us.
Yes, thank you so much for having us and for staying and listening.